much, Dr. Amin. I will now invite Mr. Tony Kirwa, a representative of Referal Hospitals. Karibu.
Your Excellency, the Deputy President, the guests who are here, all protocol observed. It's quite a challenge to speak after giants have spoken, but I will attempt, Your Excellency, to speak. You know, speaking after you have spoken is really, and the senior doctors here. But what I will do is, we have already mentioned quite a number of what I had wanted to say. So I will enrich and concretize issues which have been brought here. Last week, Your Excellency, you met people with disabilities, and I listened to you. And we were saying, a country is judged by how much we support the vulnerable. There are no more vulnerable people like the sick people in hospitals. They are very vulnerable. And when you look at how much we allocate, Your Excellency, to health sector, both at national and at the county level, it's just 4% or less. Rwanda is doing 23% of their budget. So even if we talk about all these issues, and you have always said it has to be very deliberate, we have to be very determined and allocate resources where it is. 20 years ago, Your Excellency, 2001, there was a meeting in Abuja of African Union, and we agreed as nations of Africa that we'll put at least 15% of our money, 15% of our national budget. Now we are doing 4%, Your Excellency. We need to do something about that. Because Malawi is ahead of us, Seychelles is ahead of us, about 5 or 6 countries have met that, Your Excellency. So if we don't allocate that amount to health sector, then we will be grappling with a lot of issues at the county level and at the national level. We have said we will address issues of NHIF comprehensively. We need the money. I have seen we have belabored the point of NHIF. NHIF remains the, I don't want to say, maybe Dr. will oppose it, but the only silver bullet we have to fight in order for us to achieve universal health coverage. What we need to do is to turn it around. I don't know how we will go about it, but my position is this, Your Excellency, that anything we need to do to help NHIF, so that when I go to the hospital, or any person, or people who are below the pyramid, are able to get medication. That's the key thing. How we go about that, that is the elephant in the house. But for us who have worked with NHIF as a, user, as a beneficiaries by being treated and helped by them, we have seen they have issues with the human resource. It's a big issue. Go to Eldoret. They are not able to process those issues. Issues of ICT is becoming a problem. And the numbers. Hospitals are marketing for NHIF. All of us, leaders in the churches, join NHIF. So the numbers is overwhelming. And we need to find a way of helping NHIF. Now, Your Excellency, with the help of the budget which you will allocate, I'm sure for that, we will really focus on issues of family medicine, family health, community approaches, population health, that will be cost effective and has high impact. These institutions which we are building through devolution and whatnot, we have to find a way of linking them at the grassroots level, from the household up to the national referral hospital. We have to find a way so that they can impact. We have to put a lot of emphasis on, Your Excellency, on prevention. We have talked of prevention. We need to find a way of preventing these diseases. Early diagnosis, we have to find a way, and the referral of common diseases. You have asked us whether we need to do something about the referral institutions. Your Excellency, you are aware that we have about 5 or so referral hospitals. The Apex, the level 6, the KNH, the MTRH, the Kenyatta University Teaching and Referral Hospital, Mwai Kibaki in Othaya. Now, when we say these are referral at the Apex, we need to support, totally support, in terms of infrastructure, manpower, technology, talk about anything, so that we don't need to refer a patient from one of the Apex hospitals to another Apex hospital. There is no point of us in MTRH referring a patient to KNH, just because we are not funded the same way KNH is funded. It doesn't make sense. So if we say these are Apex referral institution, let it be seen that they are really Apex. Now, those Apex referral hospitals are not enough, Your Excellency. We need to cluster areas, counties. And we are proposing in this meeting, Your Excellency, that in Garissa, we should have a referral hospital of the level of KNH. In Embu, we should have one. In Machakos, we should have another one. In Mombasa, we should have another one. In Bomet, in Kakamega, we should have a referral hospital. Why do I talk about even about Kakamega? It will really help us. MTRH takes care of 22 counties. It's half of the entire country, from Nakuru all the way to Busia. We are seeing, Your Excellency, 1,500. If you check from the government, they will tell you MTRH is 1,000-bed hospital. It's 1,000-bed hospital. Look at the math. We are admitting 150 every day. Where are the rest being placed? We can't send them away. That's a government institution. They have to find a way to where to sleep. And that's why we're ending up with having 2 or 3 patients in one bed. The infrastructure stopped. I think the government stopped building a hospital with the Nyayo wards in the 80s. Whatever you are seeing in MTRH is out of friends of the hospital, partners. We are partnering with Moy University, and Moy University gets support from Indiana University, all Northern American University, by virtue of research. And that's where we want to spend more money again, on research. Best practices. Yes. We want to see government, out of that 15%, this is how we will get this support, Your Excellency. So, I'm answering quite an issue so that I will have very few questions from Professor Ndi. And I'm not lucky, the Vice Chancellor not here again to give me the same, what he has given the Deputy President. What I am preempting is that we have talked about healthy, they call healthy what, Service Commission. Many people fear to use that term. What we are proposing, Your Excellency, is that there should be a way whereby a doctor in Alupe in Busia and a doctor in Elwak or in Machakos can be brought on board so that their salaries are the same. If it's posted to Nairobi, to NMS, it will earn the same amount. That's what we are saying. Let us structure it so that elder workers can find a way their welfare is catered for wherever they are. So this urge to go to Nairobi will not be there. Because I'm earning the same salary like someone who is in Nairobi, if I'm in Alupe. But as long as someone in Alupe, a doctor in Alupe, earns very little money compared to a doctor in Nakuru, then there is that discrepancy and becomes a big issue. We need to address that issue. Now, we have talked about doctors and health workers going on strike. In MTRH, we have found a way. And we hope other institutions can follow it. For the last 5 or so years, we have never had any industrial unrest in MTRH. And Mr. Shet Panyako is here, he can witness. And he knows the secret, what we employed. Can I say the secret? We talk with the unions. We don't fear to talk to the unions because they also mean well. We even remind them about their CBS that is due for you to renegotiate for your CBA. They don't need to go on strike on that. They don't need to do that. We have also brought them on board. Any decision made in the hospital, we involve all the unions. They are major stakeholders. Yes, and this is what we need to, populate along the way. We talk with them. We have put them in national NHIF committees. In every meeting of the board, they are also represented there, And we have so many, we are work harmoniously with the unions. And that can also be replicated elsewhere. Your Excellency, as I wind up, I want to say that we need to put more emphasis also on family medicine. You can imagine a doctor, we can say a mother with a baby coming to the hospital. Both of them are unwell. And they see Dr. Duale at his clinic. So, Dr. Duale, being a family medicine doctor, he can even sort out the mother and then sort out the baby. This is where we want to go. As we are emphasizing on multi-specialties all along, we should not focus that these communities we come from are resource-strained. If you can walk into a hospital where you can be seen by even one doctor without going to be seen by another subspecialist and another one, that's a lot of money. In conclusion, we want to say this, Your Excellency, as people have talked and given some examples. And there is one example I believe you need to hear. It was very difficult some years to be helped by NHIF if you are a renal patient. If you are a patient with kidney issues, it was very difficult to be sorted out by NHIF. One, they forced you to be admitted to be given dialysis. So they loaded the beds in the hospital. Then you could go in the morning and get dialysis, but they say, we'll treat you as an inpatient. That means sleeping in the hospital. And even after sleeping in the hospital, they say we are not able to clear the entire bill. We'll pay 5,000 shillings, 3,000 on top of that you have to pay yourself. People used to come with consumables, 5 liters of liquid to be used in the machine. And after you have been dialyzed, you go back with your 5-liter container. That's what reminds you are coming from dialysis. Hospital lobbied NHIF for so long. NHIF later on accepted to do dialysis without necessarily forcing you to sleep in the hospital. But they say we are not going to do the kidney transplant. It's very expensive. We said, what do we do then? This is a person who we have engaged. We have convinced him to be a member of NHIF. Where can he go elsewhere? Where can he go again to get other money? After we had done several kidney transplants all over, unlike before, and the prices went down in public institutions, NHIF now agreed that they are able to do they are going to support the kidney transplant, which was very good. In the public hospital, kidney transplant is done and NHIF pays. Now, the biggest issue now, Your Excellency, is NHIF does not pay for your medication, which is lifetime. Although your kidney was, found to be compatible with the other one, blah, 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 the body still continuously rejects the kidney as a foreign body. So you need to take drugs every now and then. And you know how much it is, that, Your Excellency? 40,000 shillings every month. So you need to have about $500,000 to have those drugs for 1 year, for example. Now, because you are not able to foot that bill of 40,000 every month of drugs, what happens again? You relapse. You go back again for dialysis because NHIF pays. It will not refuse because it's covered. And the idea of getting kidney transplant was to get out of this dialysis, isn't it? Now, because you are going back again to dialysis, dialysis is a stopgap because you are supposed to go for another kidney transplant, which NHIF is willing to pay for you again. You finish, you replace the other kidney, you are given another one, but you are not paid for the drugs again. So we are finding these people again in the hospital, Your Excellency. It is a very sad story indeed. And that is one aspect of it. Thank you very much.
Thank you very much, Tony. I quite sympathize with especially the last episode you have mentioned. And I think reason should finally prevail the way it has before. I think it's possible to change the mind of people when they get to understand the kind of strain that you're going through. I confirm, because I have been to MTRH myself, that you sometimes find 2-3 people on the same bed and possibly another 2-3 on the floor. And it's not quite it's quite a sight many of us cannot take. But I want to ask about your experience. We tried working with counties to create facilities that are almost at the level of a referral hospital in many more hospitals around the country. Like, for example, we did, I think, 60 hospitals with ICU facility. We did other hospitals with radiology facilities. We did other hospitals with renal unit facilities. Have you experienced any reduction in pressure in MTRH? Because we now have, in the 22 counties you cover, majority of them benefited from the MES, what was called MES, the equipment, mechanical equipment service, or medical equipment services. Did you experience any difference? Do you think that if we scale up facilities in other hospitals, it will ease the pressure you currently are facing?
Thank you very much, Your Excellency. One, you have heard here, Your Excellency, that there are some hospitals with ambulance with no drivers. So it's not very difficult to realize that there are ICUs in counties without manpower. It's a very technical line of technology. So with all those, I have seen in Iten and many other places, even Our Excellency, Ms. Kenyatta's Beyond Zero, they are just lying idle. They say they don't have drivers to drive those vehicles. So we have quite a number of equipment all over, scattered all over. They don't have biomedical engineers to fix even a fuse in it. They don't have doctors to look at them. they don't have nurses, and that's what we are saying here. We have to have deliberate move to train the manpower again, the nursing. Because now even nurses have PhDs. We have nurses who take care of patients in ICU, critical nursing. So counties don't have them, and you had the challenges they were facing initially. And that's why we are saying we have to have a system, although we don't want to say it's a commission, that it takes care, it trains these people, it places them. It can even use the performance enhancing whatever, to monitor them, so that it's easy to deploy them elsewhere. Very few counties, Your Excellency, have managed to train 1 or 2 people, and still they are not confident enough to say whatever they are produced can be used for treatment. So they will still bring it to MTRH again to be read and interpreted. And that, whatever is being brought comes also with the patient. Yes. So the whole range, the whole array of, things to be done, as the Secretary General of Nursing had said, we need to do much, not only getting those items, they are lying idle many places. I remember in Wasingishu, the governor had even to donate them to us because they had no capacity to use them, And that is, it cuts across all counties. So even if we were to bring up this referral hospital I was talking about, sir, like the one of Kakamega, for example, or Garissa, we have to do a deliberate. Yeah? We have to mentor them. These big institutions, like us now in MTRH, these counties, we are getting out to help in many ways because it helps us to reduce the number of referral cases to MTRH. So we need now to move again and empower these apex referrals to be able to influence the outcomes around their areas. So we reach out there, we do deworming, malaria, many other things to prevent some of small diseases which end up in MTRH, Your Excellency.
Okay, thank you very much, Mr. Kirwa, for your presentation.
I will now invite Dr. Machogu from Pharmaceutical Society of Kenya.
Okay. Your Excellency, the Deputy President of Kenya, other leaders, colleagues, good evening, good afternoon. Yeah, I'm really happy to be here to speak directly to His Excellency. And Dr. Cohen, please just come hand out I've been told to just speak for 3 minutes, so I'll just keep it short and I'll give my presentation to you formally because my members have elected me and sent me with this information. Okay.